Hello. Yeah, we'll give it a few moments and get going. All righty. Okay, so last week we sort of ended here in this basic arrhythmia talk, and what we're discussing is mechanisms of tachycardia. So why don't we just review this one last chart here. So again, when we think about the mechanisms, clinical mechanisms of tachycardia, I think about them in two broad categories. Those are disorders of automaticity and reentry. And I tend to think of it in regards to the location of the tachycardia and the level of the heart. So at the level of the sinus node, sinus tachycardia would be the most obvious automatic arrhythmia that affects there, which isn't really an arrhythmia so much, although there are people with a so-called inappropriate sinus tachycardia. And then there is a rare condition of sinus node reentry in the uh, in the level of the sinus node. At the level of the atrial muscle, patients can have, in the automatic category, ectopic atrial tachycardia. We talked about that last week, how there can be a single focus that's beating at a rate faster than the sinus rate, or so-called multifocal atrial tachycardia, also sometimes referred to as chaotic atrial rhythm, where there are multiple foci, typically 2 to 4, that are beating at rates faster than sinus and overtaking the rhythm. And then, of course, when we think about reentrant arrhythmias affecting the atrium, we think about predominantly atrial flutter or fibrillation. At the level of the AV node in the His-Purkinje system, we have so-called junctional ectopic tachycardia representing the automatic arrhythmia, which is presumed to be due to enhanced automaticity of the His bundle. And then at the level of the AV node, when we're thinking of reentry, the most common is AV nodal reentrant tachycardia. When we're talking about AV reciprocating tachycardias, it's not an obvious automatic one, although sometimes patients who have Maheim fibers, there can be automaticity from a Maheim fiber, which does cross the AV groove. And in the reentry category, we think about either Wolff-Parkinson-White syndrome or patients who have concealed accessory pathways. And then finally, at the level of the ventricles, both automatic and reentrant arrhythmias can affect the ventricle. When we think about reentry in the ventricle, we're mostly thinking about post-MI VT, which is a common problem in the adult world that can be treated in part with ablation. We don't see that so much in children, thankfully. Okay, so we'll just do a very brief overview of therapy for arrhythmias, and then starting next week, we'll do a review of different drugs as well as in more depth, as well as cases. Okay, so terms of, we'll first start with chronic or definitive therapy. Drug therapy in general is effective for most forms of SVT, and this is a list of some of the more common agents that we use to treat SVT, which again, of course, is the most common arrhythmia that we encounter. And these are things like digoxin, procainamide, beta blockers, verapamil, sotalol, amiodarone, and flecainide are probably the most common agents that you'll see us use almost exclusively. When we're talking about acute therapy, we think about adenosine. And the reason that we use adenosine, it can be used for, well, of course, first of all, importantly, it causes transient AV nodal blockade. It's particularly useful for any arrhythmia that involves the AV node. So any kind of AV reciprocating tachycardia, such as patients who have orthodromic reentrant tachycardia or patients who have AV nodal reentrant tachycardia, which of course are the two most common forms of SVT in children. IV adenosine can be very helpful in terminating an arrhythmia. I should also mention it can also be very important diagnostically in helping to ferret out primary atrial arrhythmias or ventricular arrhythmias from reentrant arrhythmias. And so this is one of the reasons why I'm always fond of suggesting that if you can, if the patient is stable, it's always worthwhile to run a rhythm strip of multiple leads of the ECG while you're administering the agent because sometimes the effect of the agent can be transient. The other thing I'll mention is that in single ventricle patients, it is not uncommon that you need very high doses, particularly in Fontan patients, to have effect. For the rare patient who has a reentrant AV reciprocating tachycardia or AVNRT, you often need the very high dose of adenosine to see effect because of the circulation as well as the location of the AV node relative to the venous system, which is obviously different than it is in a person with two ventricles. IV verapamil also can cause AV nodal blockade. It is not as commonly used due to potent negative inotropy. And importantly, it has been shown to cause cardiovascular collapse in infants. And so that's an important point. So we don't use verapamil in children pretty much under 1 to 2 years of age. In retrospect, I think most people feel that probably if verapamil is administered very slowly, it might possibly be safe, even in infants. The problem with IV verapamil is it comes as a relatively concentrated IV solution, and so it's just very, very hard to deliver it slow enough that it doesn't cause hypotension in small children. So just because of the high level of concentration. It may be something specific to infants as well, but I think in 2024 and probably for the entire period of my entire career, we have not generally used IV verapamil for young children with SVT. But for older kids, and particularly prior to adenosine, which really was only available in the late 1980s and early 1990s, IV verapamil was a very, very commonly used agent for anyone outside of the newborn period for acute treatment of SVT. Now, when we're thinking about infants who have SVT, so you'll be consulted in the NICU, for example, or in the well baby nursery, or perhaps even in the emergency department, an infant who has SVT, probably the two most commonly used agents by general cardiologists are digoxin and beta blockers. Digoxin can be useful in infants. The predominant way in which it works is by causing AV nodal slowing, and it also reduces atrial ectopy. As we know from our talk last week, for reentry to begin, you have to have an appropriately timed PAC or PVC to allow for reentry to occur. And so if you have an agent that reduces the total number of atrial ectopic events you're having, you will reduce statistically the likelihood of having SVT. In most full-term babies and older, the dosing is about 8 to 14 micrograms per kilo per day, typically divided BID. Traditionally, digoxin is loaded when a patient is started on the medication because it takes a couple of days to reach steady state without doing that. Some of you may know that I'm not a big fan of loading digoxin, and the main reason I would say is because when it's inappropriately dosed, patients can have toxic effects of digoxin, and I would make the observation that anybody who needs digoxin that rapidly probably should be on something else, because I don't think there are many diseases where digoxin is that critical for anybody that you need to load it. That would be my own personal view, and take that very minor but not zero risk. Beta blockers, though, are probably the most commonly used agent that we use. It can cause AV nodal slowing and also decrease atrial ectopy. So although working in a totally different mechanism, the clinical effect is very similar between the two of them. And the most commonly used agent is Inderal or propranolol. And particularly in young infants, the use of this agent can be associated with low blood glucose levels. And so we typically will get glucose levels or D-sticks, at least in the first 2 to 3 doses. And so in any infant, I would say probably under 9 months of age, we would typically, if we were initiating a beta blocker, we would usually admit the patient to check the glucose levels. I guess one could do this in a clinic setting and sort of watch a patient over the course of an entire day and maybe 2 doses of the medicine, but it's hard to do that practically, at least here at Sinai. So typically, and in most places I've worked, we usually will admit a patient and monitor their blood glucose levels. Now, when we get a little older and we're looking at children and adolescents, beta blockers are used very commonly. They're effective about 60 to 75% of the time, which you might say, well, that's not a particularly high efficacy rate, but the reality is that thankfully, older children rarely will die from SVT. There are some reports of that, but that's very, very rare. And so in treating an arrhythmia that is generally not life-threatening, we can afford to be a little bit or we can be willing to accept a lower than normal efficacy rate because the agents are very safe and have a very low side effect profile. Most beta blockers have almost no impact on children. They can make them tired. In fact, I would say the vast majority of teenagers will complain of being tired for the first day or two that they started, but it's rare that that symptom persists. It occasionally does, but not very often. It can cause depression in a small percentage of patients, and very rarely it can cause hair loss. I've had 1 or 2 patients in the last 20 plus years who've complained of some alopecia associated with beta blockers, but that's uncommon. Calcium channel blockers have very similar efficacy to beta blockers in terms of preventing SVT. Also has a very low side effect profile. Verapamil in particular, really does anybody know what the most common side effect of verapamil is in older children? Okay. The most common side effect is constipation, actually. I think it can affect about 5 to 10% of children on verapamil. The reason we don't use verapamil is because, again, in little infants, we don't like that agent, and we would never use it. Remember, we discussed we would never use verapamil or digoxin in anybody who has WPW, which is a large percentage of our SVT children. And so there aren't as many patients in whom we would use it. It also comes, it has to be dosed fairly frequently if you're not using the extended release variety, and the extended release type is a fairly high dose. So it really would only be an appropriate agent for a non-pre-excited SVT child who's approaching adulthood in terms of size and age. And we don't generally use digoxin in older children. It doesn't appear to be as effective as it is in smaller children. And so generally speaking, unless we have absolutely no other option, which is almost never the case, we don't typically use digoxin for the treatment of SVT in adolescents or in children beyond the early first 2 or 3 years of life. When those simple agents, beta blockers, digoxin, verapamil, are ineffective, we typically then ratchet it up and go to the more complicated agents, and we'll discuss each of these each week for the next couple of weeks. I'll present one antiarrhythmic agent a week. And so, but just as a general summary, sotalol is a very commonly used agent. It's a class 3 agent, meaning that it has potassium channel blocking capabilities, but it's also a beta blocker. So sotalol is like you should think of as a combination agent. It is not only a beta blocker. Sometimes people mistakenly think it's a beta blocker exclusively because it has the letters ALOL at the end, like all beta blockers. It is a beta blocker, but it is also a class 3 agent. There's about a 10% incidence of proarrhythmia with the agent, and for that reason, all patients who are started on sotalol, at least in 2024, are started in the hospital setting on telemetry in order to monitor for the possibility of proarrhythmia. There are many who have argued that the incidence is not as high as 10% in an otherwise perfectly healthy child with structurally normal heart and normal function. And in certain European countries, I believe it is started as an outpatient, but in the US, there has not yet been, to my knowledge, a study showing that it is definitively safe to be started as an outpatient, although some studies have shown that there are that retrospectively you can look back on patients who have been started on sotalol in the hospital and identify a subset who never basically had a problem, and those were largely patients who had structurally normal hearts with normal function. But again, in 2024, I think it would be fair to say the vast majority of electrophysiologists still start this agent in the hospital. The other commonly used agent is flecainide, which is a class 1B agent, which is a form of sodium channel blocker. It's also a very, very effective agent, particularly useful for automatic arrhythmias such as ectopic atrial tachycardia. The reason that it has gotten a bit of a bad name in the adult world because of a study called the CAST study, which was a study conducted in the early 1990s amongst patients who had had a heart attack or myocardial infarction. So back in the 1990s, particularly in the first half of the decade, there was surprisingly little information regarding which agents were best to give to people who had a myocardial infarction. So some of you may not be aware that, the most common reason that people after a heart attack die is from arrhythmia. Presumably the infarction injures heart muscle, which predisposes the patient to life-threatening ventricular arrhythmias. And so there was a lot of interest in which agents would be safest to give patients and would be most effective. And in the CAST study, what essentially came out was that if you had coronary artery disease and you were on flecainide, on average, patients died more commonly than those who had the same level of coronary artery disease but were not treated with flecainide. So as a result, flecainide sort of got a black eye because of the demonstration that there was increased mortality. In fact, I think the study was stopped early because of that. But what has come out over time is that in the absence of coronary disease, of course, it's a very effective agent. We often will use it in very difficult to treat automatic arrhythmias, such as very challenging ectopic atrial tachycardias. As a general rule, we are a little frightened of the agent because for children, it has to be compounded. And there's a very narrow therapeutic index for the treatment for the use of flecainide. And unfortunately, I've seen overdoses even when the medication has been dosed and prepared by a hospital pediatric pharmacist. So one needs to be careful with it, but it has certainly saved the lives of many patients. One of the reasons that electrophysiologists and cardiologists lean on sotalol a little bit more than flecainide is because sotalol comes professionally made by the company as a solution. So it's a little bit more of a stable compound, and it is a more reliable compound, but probably for some arrhythmias and in some patients may be less effective. Amiodarone, which we all have used, is also a class 3 agent, but as their marketing used to say, it has all 4 von Williams classification effects. So it really is a class 1, 2, 3, and 4 agent. It was initially introduced actually as an ACE inhibitor, or it's thought to be an ACE inhibitor, afterload reducing agent. It does do that, but it was later determined after it was used that it was not a particularly good heart failure medication, but it was actually a very effective antiarrhythmic agent. Amiodarone has one of the longest half-lives of any medication known to man. In fact, I'm not personally aware of any agent that has a longer half-life. It's 45 days. It's because of that we, when we're loading a patient, we give very high doses of amiodarone, and we typically monitor patient for a minimum of 5 to 7 days in the hospital while loading, and might continue the load even for another 5 to 10 days. Amiodarone importantly, is a very safe agent in regards to pro-arrhythmia. It's very uncommon that amiodarone will cause arrhythmias amongst patients who are being treated. And that's in contradistinction to sotalol and flecainide, which have maybe as high as a 10 or 15% incidence of proarrhythmia. It's very uncommon to see that in amio. However, as you probably all know, there's a very high side effect profile for non-cardiac toxicity. It can cause pulmonary fibrosis, elevation in liver function test enzymes, can cause hyper or hypothyroidism, It can cause discoloration of the skin, particularly when exposed to bright light. And so we're very aggressive in reminding patients on amio that they have to wear sunscreen at all times in the sun because it can cause a blue-green discoloration of the skin, the combination of sun and amiodarone. It can have impact on the eye. Mostly it just causes corneal microdeposits, which do not typically affect vision, but rarely it can cause retinal disease as well. And so officially and by standard, you should really have an eye exam by an ophthalmologist when this agent is started. But because the eye complications are so uncommon, practically, we don't often get this any longer, an eye visit, but and part of the reason that we don't do it is because, generally speaking, because of all these other complications, we don't typically like to leave patients on amio for more than about 9 to 12 months, which is really when most patients who are going to have pulmonary, liver, or thyroid problems would start having them. Because of that, because of the difficulty in getting eye exams, for example, in small infants, although obviously doable, we generally have avoided doing that. But as I'm trying to explain, drugs aren't a free ride. We've already talked about a number of the cardiac and non-cardiac side effects. Drugs can have proarrhythmia. Most importantly of all, they're not always efficacious. I've just described to you success rates in the 60 to 80% range. Of course, there's always an issue of compliance with any drug. And then, of course, there's the issue of lifelong usage. And, although, 60-year-old women or men might not mind having to take a medicine every day, most parents aren't too excited about their children at age 10 having to be on a medicine lifelong. And importantly, for something like WPW, some of these agents may not actually reduce the risk of sudden cardiac arrest. And so, for example, beta blockers, some people think they might even enhance the risk for sudden death. It might reduce the risk of SVT, but not reduce the risk for death. So they're not exactly perfectly efficacious or useful. And then when we're thinking about intra-atrial reentrant tachycardia, drug therapy basically stinks. This is a chart from an unpublished abstract, but it's quoted all the time by an electrophysiologist named Steve Weinling from about 20 years ago, looking at the percentage freedom from recurrence of intra-atrial reentrant tachycardia on various antiarrhythmic agents in congenital heart patients. And you can basically see that if you look at the last column, if you have a person who has IART and congenital heart disease 24 months out, without therapy, there's only a 10%, 12% chance you're going to not have a recurrence. But if you look at all these other agents, they're all in the 30% range. It's pretty low, suggesting that medical therapy for IART is really bad. And that really is the main rationale why catheter ablation came into being or was so important because, of course, as I've just described to you in IART, drug therapy is terrible, but even in regular garden variety SVT, drug therapy is not perfectly efficacious. And so the advantage, obviously, of catheter ablation is that it is definitive if it's effective. If it's effective, drug use is not required following the procedure. And so the first question that we're often asked is, what is the efficacy of an ablation? And it really depends on what you're ablating. But if you think about common forms of SVT that we ablate in the cardiac cath lab, in most series, and certainly here at Sinai, the success rate is in the range of 90 to 95%. And we'll go through during the year why it is not 100%. So it's a complicated procedure, as many of you know, having been involved in these cases. It requires a minimum of 4 or 5 catheters. Typically, there's a catheter in the right atrium, a catheter in the coronary sinus, a catheter across the tricuspid annulus at the level of the bundle of His and AV node, and then a catheter in the RV, not to mention the ablation catheter. So it's a lot of different catheters, lots of vascular access. Typically, in many centers, it can be a procedure that involves 2 to 3 cardiologists. Some of you who've worked with me know that I work with a nurse practitioner, but it's almost always a 2-man job. There's typically a nurse, a CV tech. There's also, I haven't even updated this slide, but there's, of course, we're using electroanatomical mapping, CARTO, so we need a tech for that piece of equipment as well. We have computerized online analysis. You have to have fluoro, a programmable stimulator. So it's a very complicated procedure requiring a lot of equipment, lots of things all at the same time. And as some of you have seen in our lab, it's not uncommon that, and by the way, true in every lab I've worked in, with so many various things involved in an ablation, it's rare that you go through the whole case and everything works perfectly. There almost always is some technical snafu that requires some jimmy rigging during the case. But, when it's successful, it's a very nice feeling. This is an old example of patient in ectopic atrial tachycardia. The radiofrequency current is turned on, and after a few seconds, a patient breaks from EAT into sinus rhythm in a 5-year-old. And this is an example from a million years ago of a patient who has WPW. I'm sorry, not WPW, has a concealed pathway, and basically radiofrequency current is turned on, and immediately we notice a change in the retrograde pattern in the coronary sinus pairs, suggesting that the pathway has been successfully ablated, and we'll go over how that, how to interpret these signals throughout the year. Success rate again for ablation is quite high. This is a very old study now, almost 30 years old, but from Boston, showing success rates for various forms of SVT anywhere from 83 to 100%. And in 2015, we looked at our success rate when I was still at Montefiore, and we were successful approximately 94% of the time. So, which is, I think, fairly similar to this chart here. So very good efficacy, still not perfect, still, concerning that we are not perfect, but that's, some of the fun of the game, trying to figure out ways of improving our efficacy. There are a number of risks associated with ablation. There's all the normal cath risks, such as bleeding, stroke, infection, vascular trauma, etc. And very rarely there are serious complications, including death, ventricular dysfunction, stroke, cardiac perforation. And in the Boston study that I just showed you with those very fine outcomes, there was still about a little more than a 1% incidence of serious complication. I think in the present era, now 25 years later, the incidence of serious complication is probably less than 1%, but it isn't probably a lot less than 1%. And that makes sense, right? Because anytime you're putting 5 central venous lines in, putting in 5 catheters, heating cardiac tissue to 70 degrees centigrade, it just sort of stands to reason that somebody's going to have a complication once in a while, unfortunately. Now, when we're talking about arrhythmias, though, in the Fontan patient, and this is an example of an old-style Fontan with this is an angiogram showing a gigantic right atrium, and here's the pulmonary artery that, if you remember in the old-style Fontan, the surgeon would literally just close the ASD and attach the roof of the right atrium to the undersurface of the pulmonary artery. Patients would have gigantic right atria, and so it was a very challenging procedure because there was so much ground to cover. And the other problem with these particular types of Fontans is that they typically had multiple circuits. And if you look at pathology specimens of old style Fontans, the thickness of the right atrium is very similar to that of the thickness of a healthy adult ventricle. So not only do you have the problem of a very large area to map, typically multiple circuits, but you also have very, very thick myocardium in which it was difficult to create a big enough lesion to cause conduction block. And using older technology, there's a very famous picture of the inside of a patient who had a ablation for IART one day before he got a heart transplant. And so they had the path specimen, and you actually could not see any evidence for burns on the inside of that heart just the next day, showing how difficult it is to cause an injury, or how difficult it was. The data for standard RF of IART have generally been poor, with about 50% arrhythmia free at 2 years. But remember that that is still better than any of the drugs that I just showed you on that list. And in the present era, with the advent of newer mapping strategies, such as the use of CARTO or electroanatomical mapping systems, we are now able to, through a magnetic field, demonstrate the circuits more accurately, and therefore are better able to understand the arrhythmia that we're looking at. In the past, we had to sort of do it in our mind's eye. It was very, very challenging. It's still very challenging, but it's easier with a graphical demonstration on a CARTO, and this is another company that makes a similar thing. The other thing that has really changed is the use of irrigated tip catheters. So this is a very old slide showing the very, I say newer, but it was really the very first irrigated catheter was a so-called Chile catheter. That was actually the name of the catheter. And the irrigation was actually internal. And if you look here, most ablations are performed using what are called temperature-controlled catheters, where we tell the computer we want to achieve a certain interface temperature, and it will deliver as much power as it needs to get to that temperature. But when you irrigate the catheter, you basically can choose whatever power you want to deliver to the tissue, and you can see in this graphical demonstration how irrigated lesions are substantially deeper and wider than non-irrigated lesions. So the big advantage you could imagine in someone who has IART and has a very thick atrium is that you can make a much more effective lesion. But the downside, of course, is that with bigger lesions, you take a bigger risk, right, of something very potentially bad happening. You could perforate somebody, you could injure normal conduction tissue if you're near to that. We don't really know what the long-term effects are of making very large lesions as opposed to smaller standard RF lesions. So some of you who've done cases with me probably see that I use standard RF almost exclusively for typical SVT ablations, and I mostly use, irrigated lesions only for patients who have very difficult ablations, typically in very large patients or in a Fontan patient. Another newer technology, which is now about 15 years old, is the use of cryoablation. And in cryoablation, we are, instead of heating the tissue, obviously we are freezing the tissue. And the big advantage of cryoablation, there are two advantages. The first is that the catheter literally freezes in an ice ball to the endocardium. And that is something of an advantage if you're in a dangerous area and you're afraid that with the motion of the heart or with ventilation that the catheter may move into a dangerous area, such as the AV node, if you're, for example, ablating a parahiscine pathway. Or if you're doing an AV node modification and you're worried that you could cause heart block. So that's a nice advantage. The other advantage is that generally speaking, if one were to see something you don't like, for example, injury to the conduction system using cryo, you can turn off cryo in the first 30 to 60 seconds, and in the vast majority of cases, conduction will recover. That is not true with radiofrequency, whether using standard or irrigated tip. If you put even 2 seconds in the wrong location, you could end up with a permanent lesion. And so, so those are two very powerful potential benefits of cryo. But the disadvantages, and the reason why you don't see Dr. Love or myself using this with any regularity, is because A, the catheter is very, very stiff, and it's challenging to get it to go to as many locations as you can with an RF catheter. But the most important reason we don't use it as often is it doesn't work as well. The efficacy rate is probably about 5 to 10% less than radiofrequency ablation. Now, people who use cryo more frequently or more commonly will tell you that what I just said is erroneous. But what they do in order to increase the efficacy is they put many, many more lesions in. So typically in an RF ablation, we might put 2 or 3 lesions in a particular focus. People who do cryo almost exclusively or more commonly will typically put 5 or 6 or even 7 applications at the same location, essentially just creating a bigger and bigger cryo lesion there. So we've talked about irrigated catheters. Another new technology, which we've been using for the last 4 or 5 years now, are so-called contact force catheters. So most of the new, more modern ablation catheters can actually measure the amount of force that's generated between the catheter and the myocardium. And that's important because it allows you to know if you're actually touching the heart. Sometimes we can be ablating and we can see power and temperature and fool ourselves into thinking that we're actually ablating myocardial tissue, but we are not, in fact, touching the heart. And so for some indications, using a catheter that can measure the amount of force that the catheter is making against the myocardium would be very helpful to help us understand that we are actually touching the myocardium when we're ablating, which would seem to be self-evident, but is actually not always the case. And typically, for example, Cardo would say that you need about 4 to 6 grams of force minimum to demonstrate that you are actually touching the heart. So just to summarize, we're refining newer mapping strategies to understand things like scar anatomy and its relationship to IART. I didn't even mention today, but there are surgical approaches to reduce rates of IART, and some people in some centers are even doing prophylactic RF or cryo lesions in the operating room to try and avoid IART. We're not exactly sure how effective that approach is, and it's being abandoned by a lot of centers, but it is at least a theoretical thing that might be beneficial. Newer catheter design we've talked about, such as cryocatheters, contact force, irrigation. And then, of course, many of you know that I'm very interested in lower fluoroscopy protocols and using 3D electroanatomical mapping to reduce exposure to the patient and to the operator to ionizing radiation. So I think we'll stop here. Does anybody have any questions about this? Okay. If not, then what we'll do is next week we'll talk about 1 or 2 drugs, and we'll start with some interesting cases. So thanks for joining, everybody. Hope you all have a good day.
Thank you.
Bye-bye.